I said yesterday, it's a pleasure to be here. It's a pleasure because it's like coming back home. So what I've been asked to talk about today is what is asymptomatic carotid disease as it is today, with all the technology that we have. Are we being too aggressive, and which therapy should we be using on what? So the first thing I'm going to start out with is really what is asymptomatic stenosis? What does that mean right now? So qualifying, the definition would be that there's been no qualifying event in the last 6 months or an incidental discovery, so there's no clinical scenario that happened prior to this, and incidentally you find greater than 70% stenosis. So there's a couple of problems with this theory of asymptomatic carotid disease. One is patients may have had a clinical event that is not reported. It's way in the past. Stroke detection is far less sensitive than MIs are, for example. We have a great MI program where heart chest pain patients come in. There's no accepted biomarker. There's no accepted imaging marker. So it's actually really hard to tell what truly is an asymptomatic carotid stenosis and what isn't. If you go simply by asymptomatic carotid disease, what's the natural history? We know that by the studies that have been done in the past, and we know that if you just went with medical management, of course these are old studies, your stroke rate is much higher than having than if you had revascularization, which is why we tend to revascularize asymptomatic carotid disease. However, right now, medical management has significantly changed compared to what it was in the past when these studies were done and recommendations were done. I think the most important things that we now appreciate is, we were just talking about it, is the statin, and then of course the diabetic glycemic therapy, smoking cessation. This seems to be really, really, really important in preventing recurrence and even treating. But I will say, can you back up for me, please? Thank you. There should be one other. Well, based on medical therapy, you can see that there is low lipid lowering versus non-lipid lowering. It reduces the risk, but it does not completely reduce the chance that you're not going to have a stroke with medical therapy alone. My slides are kind of jumping around, guys. I'm sorry. So the other problem that happens with best medical therapy is compliance. And this is a real life issue, meaning when we talk to our patients and counsel our patients, how frequently are you told, I stopped taking my statin because my leg hurts, or I didn't really feel good on it, or I stopped taking my antiplatelets, or I simply forgot. So because of all of these things, arguing that best medical therapy should be a replacement for asymptomatic high-grade carotid stenosis, I think is a mistake. And I do not think that is enough to prevent strokes, given the risk. So why do we treat asymptomatic carotid disease? The first reason is, of course, we're trying to prevent strokes. Can we do better with our treatment algorithms and our management? Absolutely. But number one, we want to prevent strokes. Number two, we've talked today about cognitive decline. We're starting to see a correlation between even asymptomatic high-grade stenosis having some kind of multiple issues, probably embolic, that now cause cognitive decline. And then the other problem is asymptomatic carotid disease is all lumped together between 70 to 79 and 80 to 99%, which is not the same. Clearly, we have a lot of data that says the higher grade stenosis are associated with a higher risk of stroke. The other things I think we should be paying attention to is really, in asymptomatic carotid disease, is it truly silent? Have there been previous MIs, progression of disease? Is it an unstable plaque? We should start looking at the plaque morphology with MRI. Is there intraplaque hemorrhage? Is there evidence of embolization? We've talked about TCD today. And I think all of these things add up to having a higher annual stroke risk than we once appreciated. And I think these things need to be considered when you're looking at a so-called asymptomatic patient, that truly what is their risk of having a stroke if you do something or do nothing. So apart from the risk-benefit ratio conversation that you had with a patient, the last thing I'm going to propose is your ability. Which one are you most comfortable at that you can deliver the best possible results, including the life expectancy of the patient? This should be the discussion that's going on with your informed consent with your patient. So where does that leave us now? SVS says if you have an asymptomatic carotid patient, greater than 70% stenosis, best medical therapy and carotid endarterectomy should be what is considered the best treatment. I think the caveat to that is, in asymptomatic patients specifically, the the stroke and death rate has to be less than 3% at 30 days. Now, I come from Buffalo. We have a very good neurosurgical program. They have an extensive history in doing carotid stenties. They have been the trailblazers, and frankly, they do fantastic. The patients that I cannot offer a TCAR on or a carotid endart on, I happily send it their way, and these guys have been very, very good with carotid stenting. So then which way do we go? Are we going carotid endart? Are we doing carotid stenting? Are we doing TCAR? Which one are we doing? Well, the results for this is really not out. CREST 1 basically said, you have a lower minor stroke rate if you do carotid endart, but then you have more MIs with endarts and less MIs with carotid stenting. We started to recognize the cranial nerve palsy at 5%, which wasn't really something that was discussed before. And ironically, younger patients did better with carotid artery stenting, and older patients did better with carotid endarterectomy. So where does that leave us with Silk Road and TCAR? We just talked about this. This is a fairly simple procedure. You just saw a live case. And when you look at statistics, which have also been discussed, it tends to be a little bit safer than transfemoral carotid stenting in terms of the number of strokes probably related to embolization during transfemoral carotid stenting. And if you look at it in comparison to carotid endarts, based on the Quality Initiative Surveillance Project that all of us participated in, part of the VQI registry, you can see that TCAR looks like it's actually safer than carotid endarterectomy can be. Of course, we're waiting on the results of CREST 2, which is one of the largest carotid trials that are currently being funded. And the question we're trying to answer is, what is the best way to treat asymptomatic carotid disease, which is why I stand here today. So I think at the end of the day, the conclusion probably is, whichever procedure you're going to do, whether it's going to be a TCAR, a transfemoral carotid, or a carotid endart, you have to be able to do it in these asymptomatic patients in not just 3%. I agree with Dr. Schermerhorn. I think with 2% or less incidence of having stroke or death at 30 days. So to answer the question that Venki posed to me, a carotid asymptomatic disease, when and how do we intervene, and are we too aggressive? My answer is no, because not all symptomatic carotids are really the same. You have to parse out by plaque morphology and by degree of stenosis and by risk factors. Secondly, not all interventions are the same, and not all interventionists are the same. And now with the new CMS ruling, where transfemoral carotid stent, carotid endart, and really TCAR are all on a level playing ground with standard risk, not all interventions are the same because we don't perform all our interventions the same. Some of us clearly are better than others at other things. So if when it comes to my carotid, my plea to my surgeon would be, please do the intervention that you're best at, that's best for me. Thank you.